minutes behind, which for us is actually quite good. But we'll keep pushing forward very efficiently. And I will note, actually, Jeff Pearl is listed as the moderator for PDOPPS. Jeff actually has clinic this morning, Monday morning, but in his absence, I would like to anyway give a warm thanks to Jeff for all of his work with leadership of the PDOPPS study. It's just tremendous. And as folks in the community know, Jeff is so efficient and does so much, and is really a wonderful spokesperson with respect to the most recent in development in the PD space, and where the modality itself is headed in the future, et cetera. So just did want to give a warm thanks to Jeff. And as Jeff is not available, Ron Pizzoni will also moderate this section. Ron is very closely involved with the PDOPPS study as well. So, Ron.
Thank you very much, Bruce. If we could go on to this slide right here. Yeah, so currently the PDOPPS study is ongoing, and with study sites in Canada, the United States, the UK, Thailand, South Korea, and Japan, as shown here, with data from over 11,000 patients in over 230 PD facilities across 6 countries. And if you could go on to the next slide. So today in our autumn update meeting, we'll have 2 presentations from PDOPPS, and the first presentation will be given by Dr. Hideki Kawanishi from Japan, and Dr. Kawanishi, it's actually probably about 10:30 at night there right now, which we greatly appreciate you giving this presentation so late in your evening. And Dr. Kawanishi is one of the leaders of the PDOPPS study in Japan, and which we're so greatly appreciative of. So Dr. Kawanishi, if you could just go ahead and then present on this really interesting finding of these outcomes in the Japanese PD population.
Thank you, Ron. Introduction to me. Today I talk to the Japanese PDOPPS data. Next slide. So the background is, so there's a few reports to cause-specific mortality, transfer to hemo and hybrid dialysis, and hospitalization rate from Japan. This study aimed to identify reasons for transfer to hemo and hybrid dialysis, and the reason for hospitalization reports in the PDOPPS from Japan. Next slide. So sorry, so my slide is my first slide is disappeared. So I explain to the first slide. So the Japanese history of PD in Japan is that is 14 years. That is started in 1980 CAPD, and the increasing the number of the PD population in the last century. However, this century, the number is not increasing. That is less than 10,000. So, however, this slide is several years, slightly increasing of the PD population. Maybe slide back. So maybe that is influence from the reimbursement system supported to PD in Japan. Next one. Next slide. So history of the PD in Japan is that is a hybrid therapy. 1996, we started hybrid PD and hemodialysis. And the 23 ISPD committee accepted to the hybrid therapy at Seattle in ADC meeting and San Diego in ASN meeting. And 22, the reimbursement system in Japan is accept hybrid PD and hemodialysis. After that, the number of the hybrid therapy is increasing. Now is close to the 20% PD population on hybrid. Next one. Concept of hybrid. That is 1 time chemo and 5 or 6 days peritoneal dialysis. It is that is defined of easily to define of dry weight in PD or maintenance of the dialysis dose. Next one. Next slide. So method of this study is so that we use a phase 1 of PDOPPS study, informed of information of all cause and cause-specific mortality and hospitalization and permanent transfer to hemo and hybrid dialysis or collected and during the follow-up and rate calculation. Next one. So the 808 patients in analysis of mortality and transfer to hemo or hybrid dialysis, and 749 patients in analysis of hospitalization. Next one. Reason of all-cause mortality and hemo transfer or hybrid transfer. Every outcome is increasing of time on PD vintage. Next one. Hospitalization rate. In Japan is a higher hospitalization caused by peritonitis. This data was presented Jeff and Vaudeville in PDOPPS peritonitis data in MDT. And cardiovascular mortality is higher in last 3 years. However, fluid overload is only first year is higher. At late years, that is a decline. Maybe that is a reason of transfer to hybrid therapy in Japan. Next one. Next slide. That is a related reason for hemo transfer or hybrid transfer. Transfer to hemo is main reason is peritonitis. However, transfer to hybrid therapy is salt or water clearance. That is reasonable. The reason is, I talked to you, the cause of the hybrid therapy is so the define of the water clearance or maintenance of the dialysis dose. Next slide. That is the same talk in the incidence or prevalence patient in hemodialysis transfer or hybrid transfer. That is the same tendency. Next one. Next slide. So, event rate for hemodialysis transfer or hybrid transfer by facility. So there is several variations. However, statistical analysis, there is no difference in each facility transfer to hemo or hybrid dialysis. Next one. Next slide. However, hospitalization rate by facility is different. Depends on each facility. We need a further discussion to this point. Maybe that is in relation to the peritonitis rate in each facility. Need a further discussion. Next one. Conclusion of my talk. So the rate of mortality for hospitalization and transfer to hemo or hybrid dialysis is relatively low compared in other countries. Approximately 1/3 of transfer of PD and to hybrid therapy and transition to hemo or hybrid variation across facilities. Further study is needed to understand reason for the difference in use of hybrid therapy and impact of mortality versus strict to hemodialysis alone. The reason for the high inter-facility variation in hospitalization rate, which may inform how to further reduce hospitalization rate from Japanese PD population. Thank you for your attention.
Dr. Kawanishi, thank you very much for giving such an excellent presentation. And these results are so interesting. It's the hybrid therapy is quite unique to Japan, across all of the countries in PDOPPS and even in countries outside of PDOPPS. And to see how it then allows patients still to continue PD to some extent as hybrid therapy, and particularly for patients who have solute removal issues as the peritoneal dialysis membrane changes over time. So this is very interesting, and the large differences in hospitalization rates across facilities is really it's so interesting to see such large differences, and so we really look forward to additional studies to help further elaborate both on both of these aspects. I guess there's
thank you very much. Thank you.
Maybe there's a question in the Q&A section. Is that right, Lauren? I see that you.
There's a question. Yep. There's a question asking if we could explain a little bit more about hybrid therapy.
I think that is important. I talked to. So several years ago, ISPD ad hoc committee talked to. PD is neither defined of the dry wave. So that if you use a hybrid therapy, it is easy to make a dry weight for the PD population. I have said this 20 years, I talk this point. Or other talk is, it is easy to maintain the dialysis dose. Now in the PD population today, so the standard dialysis dose is over the 1.7 kT/V. However, if we put on the dialysis one times a week, it is easy to maintain the kT/V over the 2.0 or 2.1. That is the concept of the hybrid dialysis.
And Dr. Kawanishi, do almost all of the patients who receive hybrid therapy, do they they get hemodialysis once per week for 4 hours? Is that the usual approach, or for the majority of patients, how often do they get hemo then during the week?
Oh, that is the point. So the first step is the one-time hemo, but the patient need more. So the decline of the degenerative functions, it is very difficult to maintain the water conditions. So I use a one-time hemo to move on the 2 times hemo per week.
May I ask a question?
Thank you. Yes, please go ahead, Mark.
Yes.
Hi, Martin Murphy. Hi, Hideki. Nice to hear you. Can I ask, how do you calculate the dose for the HD and the PD in order to add them together? It's quite difficult to do. I just wondered how you work that out in terms of the KT or the V.
Oh, that is a very good question. Several years ago, we used urea kinetics modeling to the standard KT/V or to make it. However, now we use a concept of the dialysate, spent dialysate correction system. So the PD is easily to correction of the dialysate, and Japan is easily to correction of the hemodialysate, total 4 hours hemodialysate. We are analysis of the urea in the hemodialysate, spent dialysate, and the total and joined to the PD and the hemodialysis to the spent urea concentration, and the calculation of the total KT/V.
That's very interesting.
Of course, if you use other machine or the Fresenius machine easily to calculation of the KT/V during the dialysis session. So if you use this machine, it is easily to calculation of total KT/V.
Thank you. Great.
Dr. Kawanishi, thank you very much, Ben, for giving this excellent presentation. We appreciate it so much, and we appreciate
thank you.
all of it.
Okay. Right. And there was one additional question we just received, actually, from Dr. Goldberg at Vanderbilt. And that was, is the use of hybrid therapy localized to a few centers, or is it quite commonly practiced across PD centers in Japan?
Yeah, that is the standard therapy now in all of the PD facilities are accepted to the hybrid dialysis. The reason is, the maintenance of the PD in Japan is a hospital based, not in clinical based. So that it is easily to the both modality to the every facility in PD.
Yeah, indeed. And then one last question that just came through as well. Is it typically 5 days of PD, then 1 day off, and then one HD treatment?
Yeah. That is so the first time in that is the 90s. We are trying to the one. It's meaning of the PD off day. That is the maintenance. That is the preservation of the peritoneal deterioration. So the 1 day or 40 hours PD off day off time. That is may be preserved to the peritoneal deterioration. So that is we try. However, the decline of the renal function, it is very difficult to these 40 hours. So the PD off time. So that now in that is so that in Japan is some facility to use 5 days PD plus 1 day chemo and 1 day off PD off time.
Thank you very much, Dr. Kawanishi. That's really helpful to know, and I greatly appreciate that. So I think at this point we'll probably have to move on then to our second presentation as part of PDOPPS. And this presentation will be about the UK catheter study, was being led by Dr. Martin Wilkie and colleagues from the UK. And Martin has been a participant in DOPPS for many years, and we've just greatly appreciated his participation both in DOPPS and PDOPPS. So, Martin, thank you very much for giving this presentation.
Great. Well, thank you to the team for inviting me to present on behalf of our group. So here you can see some of the names, but there are many other contributors to this work. So this is the UK catheter study, which is essentially a local country study on the background of the PDOPPS process. So just to talk it through, it's local data collection of a specific catheter-related information, and then that's embedded within the countrywide PDOPPS study. So this is the collaboration, if you like, between a local country initiative with the international PDOPPS study. So a very valuable opportunity. So the outcome of the goal of this study is to determine the optimal pathway for establishing a new patient onto peritoneal dialysis. And so we're really thinking about pathways of access, focusing on minimizing treatment disruption for the individual and also looking at clinically and cost-effective approaches. And so we're primarily comparing surgical and medical catheter insertion pathways. So next slide, please, if you will. So it's a prospective multi-center cohort study which started in 2015 summer and finished data collection end of 17 December. It captured center practices as well as patient components, patient experience, patient and center level variables. Next slide, please. And essentially there were two components to this. We've got the catheter insertion worksheets, and in fact there were 4 different instruments developed in the UK used locally and then linked in with the PDOPPS link data that was being collected, for example, through the interval summary and so on. And then I've just given you a clip, for example, of what the catheter events were that we were collecting, but we were interested in the first catheter event that led to some intervention, so we've summarized them there. So next slide, please. And this gives you some summary study recruitment data. And what I'm going to show you today are some inferences from the study. I'm not going to give you the final outcome yet, because we've not done the final analysis. We've been looking for the data, we've been sorting out the missingness, and we've been asking ourselves some basic questions. The protocol was pre-published in 2017 in PDI. So we recruited 785 individuals at 44 centers. You can see that from July 15 through to December 17. And the primary outcome was the occurrence of a catheter-related event following insertion. Now, patients were recruited prior to catheter insertion. This is rather unusual because normally for PDOPPS, the counting starts once they go home on PD, but here we were recruiting them prior to that. And you can see we were collecting events, but also patient outcomes, including health-related quality of life through the SF-12, which is used to look at the health economics, for example, satisfaction with care, and various other components. So if you look at our total of 785 patients, 465, that's 59% had at least one catheter-related adverse event in the first year. And you can see them broken down there. 29% were catheter function, 5% peritonitis, 8% exit site infections. There were 13% hospitalizations, 5% had more than one event. So next slide, please. Now, as we published in the protocol, the first level of analysis was to do the sequence of regressions model. And you can see the way it's set up as a graphical Markov model. On the right, you've got the patient demographics, the first step. And then after that, fed into the comorbidities, and then the dialysis unit and level measures, and then primarily aiming at the pathway. So this is a generalized linear mixed effects model to account for clustering of patients in centers. And then we get the events. So that's how the graphical Markov model is set up. So next slide, please. So we start to come into some data here, and all I'm really going to do in the next few data slides is give you a feel for the data, and then I'm going to show you some bar charts which give us some unadjusted information. But you can see gender, 60% males, 60% males, 36% females in the surgical pathway, slightly more males in the medical pathway. As you can see, overall 64% males, the age around about 58, body mass index about 27, about 9%. Interestingly, actually, in the surgical pathway, we had a lower percentage of non-whites than we had in the medical pathway. You can see the APD-CAP ratio roughly 40%. Hang on a minute. It's always a question of the denominator here, how that's all been stacked up. So the denominator is going across the way there, but you can see the differences numerically at any rate. And diabetes presented, so about 30% diabetic. So next slide, please. This is showing according to the surgical or the medical pathway. And what I'm really interested in showing you here are the different pathway-related components that we were interested in looking at. So, for example, we want to analyze the effects of different components of care aspects, if you like, on the outcome. So, for example, we've got in there exit site planning, deep cuff planning, the use of nasal mupirocin, late presentation, the quality improvement, a question about quality improvement, the duration of training, affiliation of nurses, and you can see a whole variety of other factors that we've used in the analytical approach. So can we go on to the next slide, please? So if we look according to whether there was an event or not, again, sorry, it's rather difficult to see, but I've here presented it according to events or not. So in terms of events, females were less likely to have an event, so about 32% of females had an event. So that was lower than males, for example. I think the best thing for us to do actually is just to move through these slides, which are rather hard to read. So can we just move through the next one, if that's all right? This tells you about the catheter insertion procedures according to events or not. I'm going to present this on the upcoming bar charts. Next slide, please. And then we'll move to the next bar chart. So there we go. So when we get to bar charts, you can start to see some of the relevant information here. So this is the unadjusted information that we've got so far. So you can see comparing the surgical pathway, which is basically open surgical and laparoscopic, with medical insertion, which is percutaneous, that may also be peritoneoscopic. You can see that we found overall a higher rate of events in the surgical pathway than we saw in the medical pathway. This is unadjusted, so it needs to be adjusted for all these covariates. So that's surgical versus medical pathway on events. If we go into the next slide, please. You can then see by gender, interestingly, among males, there was a higher frequency of events, of catheter-related events, than there was in the female population. Next slide, please. If we look at the body mass index, we didn't see any difference between those who had events and those who didn't have events, according to body mass index. Next slide, please. And this one is looking at diabetes, and interestingly, those who had diabetes on the right half of the panel, 67% with events versus 33% with no events. So there's a higher prevalence of events in those with diabetes, for example, than those who didn't have diabetes. Next slide, please. And this one is looking at PD subtype. And interestingly, if you look at that on the left-hand side of the panel, you can see among APD, events are more common than in CAPD. That's not surprising. It's kind of intuitive in the sense that if you're asking more of the catheter, probably more likely to have an event. But this is, again, unadjusted. And it may well be that APD is used more for late presenters, for example, and that there's some adjustment that's required there. Next slide, please. So this one's looking at exit site planning, and interestingly, you can see on the right-hand side where there was exit site planning documented, actually the event rate was higher than where there wasn't exit site planning, so that's counterintuitive, and obviously we need to see what the adjustment tells us about that. If we go into the next slide now, please, you can see the use of nasal mupirocin, which is used for 3 days prior to the procedure to reduce the risk of Staph aureus infection. And you can see on the left-hand side of this panel, those that had no nasal mupirocin, 61% had an event, whereas on the right-hand side of the panel, those who used mupirocin, only 55.7%. So there seems to be some trend there that mupirocin was beneficial. Next slide, please. And this is something which is interesting, just that in the UK, about 18 of those centres, of those 44 centres, were transplant units. And, was there a difference in the event rate? And there's a slight difference in the event rate. Transplant units more likely to have an event. Possibly that might be to do with the open surgical pathway may be more commonly used in the transplant centres, but we don't know. So moving on now to another way of looking at the data are these bubble plots, and they show you by the size of the bubble, the size of the center, or the number of patients in the center. So if we look on the left-hand panel, you can see the proportion of catheter events going from 0 to 100% at the top, and on the right-hand side, late starters. And again, so just to give you a sense of the data before we put it through the multi-state model, there seems to be a sense that there's a relationship between late starters and events that we don't absolutely know, but that's one of the interesting trends that we've seen in this data set. And then on the right-hand side, we've got, again, events, but this is according to whether training is done by the hospital or with a third party, in other words, for example, a third-party provider, or whether the training's all by hospital-employed nurses. And you can see what we thought was interesting on the left-hand side. Perhaps there's a narrower distribution of events where there's third-party training, possibly suggesting more consistent training, but we don't really know. So moving forward onto the next slide then, just to sort of summarize where we are just now in looking at this data, we've currently been undertaking exploratory analyses. And what we see so far, for example, is we saw a higher event rate among surgical pathways than medical. That's unadjusted. We saw a higher event rate among APD than CAPD. Again, all this is unadjusted. A higher rate for males versus non-males. We saw transplant centers had a higher rate. The use of euphemeparison was associated with a lower rate of events, and the use of and diabetics at a higher rate. We didn't see any impact of body mass index on event rates. We thought there was a narrow distribution of events where a third party contributed to the training, wondering about whether that represented greater standardization. And there was a possible interaction between late presentation and the event rates. So the next step is then to go through the multi-state model. And here you can see the multi-state model. So essentially, this models the catheter from the time of insertion to the primary outcome, which is the event rate. And the primary target of inference is the rate of occurrence of events according to the pathway. And the exploratory variables that will populate this come from the sequence of regressions model. So that's the Markov model that we looked at initially. So I've given you a preliminary introduction to some of the data that we're looking at in this study. We expect the full analysis to be completed by December, and we hope to be able to present the information for you at the virtual ISPD Euro-PE conference next year, which is going to be scheduled for the 28th of February. It's a reschedule, I'm afraid. So thank you for listening. I'm sorry the data looked a little bit complex and garbled, but it's currently being properly analyzed, and we will have a good answer for you shortly.
Martin, thank you so much. It's amazing all the detail that you all are collecting in the UK catheter study, and I'm sure it will be just so informative. Even some of these early trends are interesting, and then once having a chance to look at it, for instance, McPherson in terms of the outcomes related to infection and so on, and then whether like peritonitis infection before patients start training versus after training. It's just going to be really interesting. But the great deal of detail that you guys are collecting is just so interesting. So thanks so much. I just had one question. That would be: are you also collecting? I guess two questions. Patients who have a PD catheter placed, but then eventually never start PD and just go on to HD for whatever reason. And then the other one is PD catheter,
right.
PD catheter type. Yeah.
Well, we know about, so basically in terms of the health economic analysis, which has been done simultaneously, and James Fotheringham has been leading on this. So they've set up a whole series of health economic models which model the pathways, including those that go directly from catheter insertion to hemodialysis, for example, or those that go directly to transplantation in order to attribute the costs to those. So we hope that will be able to be presented at the same time, but we're waiting before, we want to make sure all the data is completely sort of sorted out properly before we start to present any of it. Do you see what I mean? Because it is quite complicated. We had a lot of discussion about the domains, trying to prioritize which are the relevant covariates to examine, and so on, before the final analysis is run through the Markov, through the multi-state model, if you see what I mean. So we want to make sure we've got that all ironed out before it goes to the multi-state model.
Great.
Your second question is about catheter type. I don't know. I think we have some granular data on whether they're straight or coiled. I don't think we have, for example, the make of the catheter, but we do have whether they're straight or coiled. Yeah.
Yeah, we do collect that in PDOPPS. So yeah, I see. Right, and so that is linked and can be used for those sites as well. Okay, well, thank you. I see the time is up for our PDOPPS session. And again, I want to, Martin. Yeah, go ahead, Bruce.
Just a couple moments more. There was one other question you may see on the Q&A there.
Yep. Transplant centers, how many surgeons perform placements via Vista? So, well, the ratio is roughly 1/3 to 2/3 throughout the study in terms of medical to surgical pathways, if you like. Now, there's a lot of interesting analytics to go on here because the medical pathways are more likely to be co-located with non-transplanting centers. Simply, I think, because if you've got several transplant surgeons at your center, then you're more likely to use the the general anesthesia open surgical pathway or the laparoscopic pathway. But what we're learning actually is centers that are able to manage two pathways seem to have better outcomes in terms of certainly getting people onto PD. So that's one of the things we're really interested in. Can we make a recommendation from this that actually it's really helpful to have a medical and a surgical pathway at a particular center? And I think that would be something that we'd be really interested in trying to find evidence for in this data set. So that's a really important question. Thank you for asking it.
Great. Thank you, Martin. Thank you again for your leadership of this project. We look forward to finalized results as they accrue shortly. Next slide, please. Thank you.